My friends, let us consider that acuity is the refined clarity of thought and perception which enables one to discern subtle truths.
Hey everyone, Dr. Livranos here, emergency physician and medical malpractice attorney. Welcome to this week's episode of the Acuity Podcast. I guess it's worth saying this is the inaugural Acuity Podcast episode, so I really appreciate you tuning in to our very first one. As always, Acuity is best savored over an indulgent and stimulated caffeinated drink. So grab your favorite fix, a steaming cup of coffee, a refreshing Diet Coke, a soothing tea, or prepare to get sweaty with a pre-workout, and let's get started. On the agenda this week, we'll be discussing a bit of an introduction of who I am and the breakdown on education between medical school and law school. And then I'll do a deep dive on heart attacks, the medical and legal pitfalls. To begin with, a little bit about myself. I currently serve as the CEO and Chief Litigator at Acuity Medical Law, a role I've held for about the last year, where I tackle the intricate issues of medical malpractice and healthcare advocacy, including more broadly, political advocacy and administrative law. Alongside this, I've been the CEO and Chief Physician at Livranos Medical Services since about 2017. My journey in medicine started at Dalhousie University in 2008, where I completed my MD. I went on to my top choice of residency at McMaster University, based in Kitchener-Waterloo, and I really loved my time there. I did my family medicine residency and fellowship in emergency medicine subsequently, both of them at McMaster. I locumed in Ontario for about a year and a half between Barrie and Kitchener-Waterloo, and then I came back to Nova Scotia, where I have practiced ever since. Almost exclusively, I practice emergency medicine, but I have done plenty of hospitalist work. I've done lots of deliveries, outpatient medicine, walk-in clinics, so quite a wide range, but I really like to think of myself principally as an emergency physician. In 2020, I returned to Dalhousie University for my JD, graduating in the class of 2023. During this time, I focused on civil litigation, negligence, and healthcare law. I graduated with a certificate from the Health Law Institute and articled at a large personal injury law firm where I helped develop their medical malpractice division. It was going great, and I really enjoyed my time there, but the firm that I was working at decided to go a different route. So I ultimately went striking out on my own, creating Acuity Medical Law. At Acuity, I represent clients from birth injuries to surgical mistakes, delayed diagnoses of cancer, and mistreatment in primary care. Everyone always wants to know, why would I change careers after almost a decade of practicing medicine? Well, let me start by saying I love medicine, which is why I still practice. Everywhere I've worked, I have always been one of the most efficient and well-respected ER physicians. I've worked alongside and learned from some amazing physicians and nurses. So I don't want to give the impression that medicine was not for me. I tremendously enjoyed it. I still practice. I'm fully licensed. Initially, I had planned on using a law degree to enter into the healthcare policy world or advancing into a political role. Maybe doing something in regulation work like at a college, but COVID changed all of that. I started to see, unfortunately, a lot of cowardice and negligence from many of the physicians in my community, and I became very disillusioned by the lack of expertise and the beneficence of the profession. I started to see an elitism and entitlement of the profession as a profoundly negative force in society, and thought that the best corrective mechanism was to hold them accountable while advocating for patients to have greater individual knowledge and autonomy. To that end, my commitment extends beyond professional roles into community service. I am a founding member and board member of the Nova Scotia Civil Liberties Association, and I'm committed to advocating for civil rights within both medical and legal context. I've also served on lots of other various boards, including those involved in medical admissions, certification, and most recently, the foundation of my hospital. I've also worked for national law firms and consulting for political candidates. I don't want to hoard information, quite the opposite. I feel it is my obligation to teach. I was blessed to receive a prestigious teaching award at Dalhousie University, and I lecture about medical malpractice and informed consent. My advocacy for free speech in medicine has been particularly notable, where I've addressed the challenges posed by the administrative state. That's what has led me now to creating this podcast. The purpose is to try and drive an autonomous individual advocacy so that people feel empowered to take control of their lives, their healthcare. On that note, let's move to the next topic today, heart attacks. Part of what I want to do is educate the populace to advocate for themselves about their own healthcare. Today, we turn our attention to one of the most critical emergencies known to modern medicine, the myocardial infarction, commonly referred to as a heart attack. As both a physician and an attorney, I'll discuss not only the pathophysiology and management of this condition, but also where medical errors might lurk, potentially leading to malpractice. A heart attack, or a myocardial infarction, occurs when atherosclerotic plaque within the coronary arteries occludes flow, leading to ischemia and cardiac cell death. This can compromise both the electrical conductivity and the mechanical contractility of the heart, precipitating acute coronary syndromes, which are notoriously deadly due to their potential to cause both arrhythmias, valve issues, and even pump failure. Let's delve into the pathophysiology some more. The underlying mechanism involves plaque rupture or erosion, which cascades into thrombus formation, which further obstructs coronary blood flow. Basically, gunk from a lifetime of blood vessel debris and damage can rupture, and when your blood cells travel by, they further block up, forming clot. This cascade of events can lead to either ST elevation myocardial infarction, or, as we call them, STEMIs, or non-ST elevation myocardial infarction, an NSTEMI, each with its own therapeutic implications. The difference between these two types is critical because they are managed so very differently. The resultant ischemia and cell death then triggers a complex inflammatory and neurohumoral response. Basically, what that means is inflammation and cell death then triggers a complex inflammatory and neurohumoral response. That is inflammation, and your own hormones can work against you in these conditions. For all intents and purposes, what I'm describing is gunk from inside your blood vessels will rupture and cause a cascade of events, including further clot from your own blood cells and inflammatory processes that can worsen the condition and cause more cell death. So what sort of investigations should you expect? First and foremost is electrocardiography, or an ECG. The timing and frequency of ECGs are critical. A delay or misinterpretation can lead to catastrophic outcomes. Serial ECGs might reveal evolving changes that are not always apparent on first presentation. And these evolving changes are indicative of ongoing ischemia, infarction, or arrhythmias. Alongside ECGs, cardiac biomarkers like troponin are indispensable. However, the interpretation of these markers also requires clinical correlation. An elevated troponin in the absence of a heart attack syndrome might not necessarily indicate an acute coronary event, but could reflect other myocardial stressors or even renal insufficiency. The timing of the markers is also important because it can take a while for them to rise and fall. So understanding when you are collecting that data relative to the clinical picture is integral for proper management. Next comes treatment. It must be swift and tailored. For STEMIs, percutaneous coronary intervention, or PCI, or in some hospitals in certain scenarios, thrombolytic therapy is the gold standard to restore perfusion. NSTEMI management often involves a more conservative approach, stabilizing with antiplatelet agents, anticoagulants, and possibly beta blockers or statins, with potential for delayed invasive strategy. So you don't need to rush to the invasive interventions like stenting or clot busting. You have time, and other medications can be very effective. Herein lies the rub for the discerning practitioner, the judicious use of medications. Beta blockers, for instance, while generally beneficial, could precipitate heart failure in certain clinical contexts, like significant left ventricular dysfunction or ongoing bronchospasm. So it isn't sufficient for physicians to just follow algorithms. They have to consider what is the patient looking like and how are they acting in front of them. Given all this information, let's focus on where errors can occur. First and foremost, variable presentations. The clinical presentation of a heart attack can be atypical, particularly in women, the elderly, or in diabetic patients. Misdiagnosis as gastrointestinal, musculoskeletal, or even psychiatric conditions is not uncommon. An attorney would scrutinize whether the physician adequately considered less typical symptoms in their differential diagnosis and whether they were sufficiently vigilant in considering cardiac disease. Next, ECG and biomarker interpretation. Errors can stem from not performing serial ECGs, misreading the subtle changes, or interpreting biomarkers out of clinical context. A malpractice case might hinge on whether there was a reasonable standard of care in the timing and interpretation of these investigations, and how thorough a history and physical were done to provide the necessary context for interpretation. Next, medication. Medication management, the inappropriate administration of medications, such as giving beta blockers to a patient with acute decompensated heart failure or using anticoagulants without considering bleeding risks, can easily be litigious. An attorney would look for evidence of a thorough risk-benefit analysis before medication decisions were made. There are no shortcuts to good medicine. Heart attacks are no joke, and their management is fraught with potential pitfalls where medical errors could occur. From diagnostics to therapeutics, each step requires meticulous attention to detail, patient history, and clinical judgment. As both a physician and an attorney, my role is not only to heal, but also to ensure that the practice of medicine adheres to the proper standards of care, safeguarding patient outcomes and advancing trust in our medical system. If you have concerns, visit my website at acuitymedicallaw.com, and thanks for tuning in.